Matt had sent them to me, and for some reason I was like, oh, I'm sure they're in the agenda, and then I realized today that they weren't. But I have them.
Oh, super. I will stop sharing. I don't know. Do you want to go through who all is on the call or just jump into it?
Yeah, who is here? Chris and Chris Gilbert, John, Kevin, Noreen, and Sandy, and Savannah. Perfect. I think Matt said he couldn't come to this one, but they're basically Matt's slides.
Okay.
So I will share lateral, hopefully. If I didn't have 7,000 open windows. Oh. See if that works.
Yes.
Great. It says read only, but it looks like it's letting me change it. Let me just save it as. STR. All right. Perfect. All right. Well, welcome everybody, and thank you guys for being willing to weigh in. I'm sorry you didn't have these slides ahead of time. I should have checked to see that they were that I had sent them out, but it's not a long set of slides, and when I had gone through it, it looked like Matt had done a pretty good job. So I think what I'll do is we'll start at the beginning like we usually do, and I'll go slide by slide. Looking at the number of the slides here currently, I don't think it's going to take us the entire time we have allotted, so I will just get started. I think the slide presentation is very well geared towards pre-hospital providers. Oops. Having a hard time showing my screen.
And it's geared for the hospital setting?
It is, yeah. Yeah, it is, because this is pretty much only in the hospital setting, but still considered an STR. So you're right, Shelley. Let me get here. Okay. Hopefully you guys can all see that. Here today basically just shows ultrasound stuff, steps that has some pictures and techniques, tips and tricks, and then in the back there's some common errors and complications. So as we go through this, please tell me if there's something additional we want on any slide. And then when we get through to the end, we can decide if there's something else we feel like is missing out of here. This was a fairly simple slide. There aren't a lot of notes on this one, but essentially as the instructor would be going through and talking about how, you know, the sound waves from the ultrasound probe are what sort of coming back and generating your image. The importance of having the correct probe. So different probes have different frequencies. And so obviously the depth and how much detail you can see depends on the probe that you choose. The other thing to teach is about the orientation of the probe. So every probe has a marker on one side, and it kind of helps you to orient the probe to the image you're seeing on the screen. And then the depth and the gain of the machine as you're adjusting it will help you to be able to see the things you need to see. And those are probably the main things from a paramedic perspective that you'd want to be able to explain. So there's that slide. This is a little bit of an explanation of how the sound waves generate the image. I think these are just more general information on why certain things look white on ultrasound and why certain things look dark on ultrasound and what that means. This is a picture of all the different types of probes that you can have for an ultrasound machine. And then here, Matt has just outlined that the linear probe, so the high frequency probe that has very good detail, but not a lot of depth ability, are the ones we want to use for peripheral IV access when possible. This shows the orientation of the probe. So the side of the probe will either have a gray line or a little dot on the side. And that's the side of the probe that will correspond on your screen with the side that has the dot. There's usually some sort of dot or marker over here. And then this one's making sure, so this is kind of how you in real time can touch the probe and make sure that you're seeing what you're supposed to see. So that's just the explanation of how to orient your probe. The depth and the gain. So adjusting the depth so that you see the sort of more superficial veins that we're looking to access. And then the gain adjustment. So the gain adjustment, this one shows basically it's undergained. And so you just see a bunch of darkness. And then you'll get to somewhere in the middle. And then if you overgain, you just get like a whiteout on your screen if you keep turning the gain up so high. Just kind of like the sensitivity. So these are the main adjustments that folks will make before they place an ultrasound. And then we get a little bit more into the indications. So I did look to see if I could find some research papers on any of these topics. There is a little bit that people have done on trying to predict difficult IV access, but these are sort of the things that we know are going to lead to more failures and more difficulty in placing IVs, but I couldn't find any specific really good reference for these. But this one does sort of correlate if someone has a history of like being a difficult IV stick. It's probably not the people that have tried. It's probably that person just has difficult veins. Obesity, history of IV drug use obviously makes it more difficult. Dehydration, vascular disease, and then folks that have anything that has led to damage of their veins, like chemotherapy, would also be people who may need ultrasound guided IV. Contraindications, most of these have to do with general contraindications for IV access in general. It's not necessarily specific to ultrasound guided IVs, but in general places you don't want to place an IV. He has a list of pre-procedure equipment in here. So these are obviously all of the things that you'll need. Some of these are going to depend on your specific ultrasound machine. Some folks use Surgilube for theirs because they come in small packets. Some places actually have small packets of specifically ultrasound gel. People like Surgilube because it is clean. And kind of mostly the stuff you'd use for a normal IV. Anything that we've missed so far in the setup for you guys? Okay, I'll keep going. Patient positioning. Again, this is relatively similar to how you would position someone for a normal IV. He has the patient sort of sitting with the arms supinated. Some people will teach to put like a towel roll under the back of their arm to kind of keep their arm a little straighter. I don't know how specific we need to get with the technique, but essentially it's just kind of where you're going to place the patient so that you can see. Because you also have to see your ultrasound machine. This is a general picture of the different veins you might be looking at.
I'm sorry, am I supposed to be typing?
And then, so this is kind of a lot of words on it, but it's helpful to see what should be maybe your first or second choice of vein based on how deep or how large they are. At the bottom, basically tracing the course of the vein, so sliding the probe up and down so that you can kind of see the direction the vein is running. And then he goes through the two techniques that are most commonly used for ultrasound IV access. Short access, I think, is what a lot of people prefer, although long access is technically the better way to do it. Most people find it easier to do it in short access. This PowerPoint slide goes through both. So here, obviously, the picture of the probe and orientation, what it looks like when you're sort of in relation to the way that the needle goes in. And then this is what it looks like when you have the cannula in the vein. And then similarly on long axis view, you'll be able to see as you're looking along the axis of the vein, as you're placing the needle, this is what the needle tip looks like coming into the vein. The next slide is, this shows the, basically saying that, we're not sure which one's superior. A lot of people think that the long axis view leads to less damage of the back wall of the vein. But essentially you're applying a tourniquet kind of high up, cleaning it, using your gel, and then basically showing from the probe. So you're going to back up a distance from the probe and insert your insert the needle sort of into the line of the image of the probe. That's kind of what this is showing. And then in short axis, it kind of looks like this. And here again, they're showing the picture here. And kind of what it looks like as it comes into view. So this is kind of slow here, but they're showing this creep method where you go in, you can kind of see the needle tip. You're going to see it kind of hit the top of the vein and tent the vein until it pops in. And then once you're more in the middle of the vein, it'll look more like that. So it's just an explanation step by step. And then he's got some pictures of what it looks like. So showing the vein in cross section, following the needle tip, showing how the needle tip enters, and then looking at the needle tip in the center of the vein. He has a page with some troubleshooting tips. And then he goes through the same thing on the long axis approach. So most of it similar in approach, and then obviously showing this a little differently, the long axis view, what the needle looks like. So the good thing about the long axis view is you can see the entirety of the needle as you're going in. And then you'll be able to you identify the tip of the needle and being able to see that the tip of the needle is in the middle. So not super different. And then again, tips for long axis view. I'll let you guys read those. This is what it looks like when you're tenting the wall of it before you sort of pop through the wall. So basically, once you reach the point you're tenting the wall, you can drop the angle a little bit and then slide it into the vein like you would if you weren't visualizing it. So that's just another couple of videos there showing it in long axis view and then short axis view of tenting. This is the confirmation test that can be done, a little bit different than just seeing the flash of blood. So I think obviously when you see the flash of blood and you're able to flush it, we usually feel fairly confident in the right spot. But the other thing you can do is they have this flush test, the saline flush test. if you're visualizing it as you flush it with saline, you can actually kind of see the bubbles from the saline going in with the blood, and you're able to see it when you visualize on ultrasound as you're injecting the saline. So that can be helpful as well. And then securing the catheter. And these are just tips for using the ultrasound. Possible complications. These are just IV in general complications. And then he's got his references that he used. And then there's a couple, a resource guide PDF that he has in here, and this other POCUS Made Easy resource that he put the link into the back.
Those are great slides.
Yeah, so I really didn't have anything personally that I would add to this. But I will certainly go back through any of the slides, and then you guys can feel free to suggest any other thing that you think might be needed in this presentation.
I think on slide 8,
Okay.
for indications,
Okay.
just a history of needing ultrasound guided placed IVs. Because sometimes it can be a mental thing with patients too. So they'll come in, they'll say, hey, they always have to use ultrasound guided IV. It used to be kind of like this coveted thing of ultrasound guided, but it's pretty common practice now. So if a patient comes in that has a fistula and they only have the right arm, they could say, hey, I normally get ultrasound guided place. Then that just kind of lets them know, okay, you don't have to, because it used to be like this weird thing where you'd have to have 2 failed attempts without it before. But now I think sometimes we're going straight to ultrasound guided IV placement.
Maybe should I put this at the bottom then, the numerous failed attempts, so it doesn't seem like that's the primary reason?
Yeah, I think that's probably a good idea.
And then we can kind of make it more like it's a reason, it's not the number one reason necessarily.
Yeah, because now
that's true.
if you get a IV drug user or someone that's morbidly obese, they go straight for those ACs. If they missed them, we start limiting places we can go now.
Yeah.
The only other thing I didn't see that I missed it because pilot Kim was talking was, is there anything that talks about in the larger IV catheter, the longer IV catheters? We found at my previous hospital that our dwell times went up significantly when we used longer IV catheters. So like a typical 22 gauge in pediatrics, and I'll leave the pediatric part for after this, is an inch, 1 inch or 1.25 inches. And then for our ultrasound guided, we had 1 3/4. We even had a 2-inch 22 gauge.
Yeah.
And I didn't see that where they talk about that if you're going for a deeper vein, that you'll want a longer catheter if possible.
Yeah. Let me see here if I find the. So I wonder if I could find a picture with catheter length.
And I can't remember all the lengths off my head, but I could look them up if I need to after.
But I bet there's a picture of like a bunch of the lengths, you know, like where it's like, oh yeah, here's kind of one. Let's see. Copy that picture real quick.
We'll probably put it somewhere between maybe 10 and 11 or 9 and 10.
Okay. You guys still looking at the ultrasound? Or you're still looking at the slide?
So probably right after the pre-procedural equipment.
Okay, so let me add a slide here.
Just catheter length selection if they have them.
Yeah, there's that picture. I don't know that that's the best one, but that shows the couple longer ones. And then there's Yeah, because these are like the longer 1.75 or 2.5 inch ones. Those are the ones you're talking about, right?
Yeah.
These
I'm
little
actually-
bit longer ones. We
Yeah.
use different ones in RED, but
I'm looking. So there's a chart that has one. And I just wonder, not all institutions are going to have them. Like I'm guessing if we're out on the reservation, these
sure.
institutions. So these are probably going to be your inside the city, your Banner Universities, your St. Joe's,
Yeah.
Mayo's, Osborne's, like that may have
There's
them. But
also this picture for like deep access. We can
deep
make one
access.
like IV length for deep access or something like that.
Yeah.
Hey, Chris.
Yes.
So my team, we use our 20 gauge is an 1.75 inches. Our 22 is an 1.75 inches. And then our 24 is an 1.25 inches that we use specifically for our ultrasound kit.
And that's, yeah, I'm looking at a chart. Those are all those are your traditional lengths, except for the 20 is a little bit longer. And then they actually make a 4.8 centimeter 20 gauge as well. So they make longer catheters. So it's just something to think about if you're going to do a vein that is below 1.5 centimeters, you'll want those longer catheters.
Mm-hmm. Something like this, or change the verbiage.
Yeah, no, that's perfect.
Okay.
And then speaking of Mr. James Cunningham, are we doing anything for pediatrics in here? Because I think site selection too. So for peds, we often use the saphenous vein.
For ultrasound, you do?
For ultrasound guided, yeah, I would use a SAF quite often.
Okay, let me. See if I can find a picture of that. I don't work in the PZD almost ever, so
No, you're good. I noticed in a lot of these we get through and then have to toss the pediatric section in, or it has to be separate, but it can be super handy. And those SAF veins are sometimes that's my first place, was one of my first places to go to. It's just, it can be easier to hold, and yeah, SAFs are good.
Okay. See if I can find. There's this picture. Could maybe steal that one. Potentially. I just have to put the reference in here. It's from a research article, but capture. And now you guys have to let me know what you think about this one. So we'll put it after vein selection.
Okay.
Oops.
Yeah, you have that one with the adult
Yeah.
arm.
Yeah, I'm just not scrolling. Oh yeah, here. This one, and then
Yeah, it's probably right after there.
and here. So there's that one.
Yep, that's the first one I found too. Yeah, that works.
Okay. To put the paper reference. It's from like a 2015 article. Okay. keep getting confused of which screen is the Google and which screen is.
Yeah.
Right. All right, I can put the rest of the reference in there.
Cool.
Okay, so pediatric considerations,
Yep. Pediatric. Yeah.
good suggestion. Any words you want on here or just the photo?
No, just a photo. Just another landmark.
Okay.
I think it goes with the top.
Okay.
I
All
mean,
right.
because I've done them in adults too. That's when people know I'm a peds nurse.
Yeah,
There's 3 or 4 IVs. Like, you put one in the SAF? I was like, you wanted access.
that's funny. Yeah, I've seen them do it all kinds of weird places, like in the scalp and
Yeah, we've done some scalp ones. I don't know that you'd need ultrasound for those, but yeah,
probably not. Yeah. Okay. Peds
that's all I could
study.
see.
Okay. I don't know if you guys use the double tourniquet technique. I see a lot of the folks in our shop doing that, but I couldn't find a lot of data.
Very
on it.
rarely, there's not a lot of data. If
Yeah.
the tourniquet's not using great, I'll use the blood pressure cuff. There's especially inside the hospital, there's a venipuncture setting
Yeah.
that you could use, but usually people know that one if they're at this point. But
Yeah.
I also know that this was, again, so highly coveted within the ED that a lot of places are going to have their own training in place. I think
Agreed.
this is a really good overview for some places, or a great starting point if they don't have anything.
Yeah.
But a lot of them, again, this was again, it was so highly protected. There was only like those 1 or 2 nurses. Now they've really allowed people to do it now that they're training.
Yeah. Yeah. I think almost everyone in our hospital does it.
And our
For a long
paramedics are
time.
going to see them at PHI. We're getting point of care ultrasound that we're going to be using. I think mostly for cardiac, for like fluid overload and stuff for sick IFTs. But we'll
Mhm.
also have a probe for IV starts in the pre-hospital setting for flight.
Awesome. All right. Anything else that you guys felt like was missing out of there? I'm glad you cut the peds stuff. That was nice. Otherwise, I didn't have much else. I can send this to Shelley for her, sort of final editing. She kind of puts everything together, but if we don't have anything else, I won't hold everybody and let you guys have the rest of your hour and a half or whatever back. Shelley, did you have anything else?
If we don't get any other edit requests, we'll bring it to the education committee meeting on March 19th at 10:30, and we can make additional edits at that time.
Perfect.
For approval by the committee.
Cool. All right. Well, I will send you these edits, Shelley, and we'll give you guys back the rest of the afternoon here.
Great. Thank you, everybody.
Well, thank you all.
Thank you.
Good afternoon.